we'll make a start. Good afternoon, everybody. There are people arriving every moment, so we have 16 of you here. It's great to see, and that's going up. It's great to see some familiar names in the list of people attending. For those of you who might not know me, my name's Andy Buttery. It's my pleasure to co-lead the Transformative Sim ASPE SIG with Sharon, who you can see there. And this is our Transformative Simulation in Practice webinar, where invited people get to tell us about what they've been doing in the field. And so I'm going to very quickly pass you over to my dear colleague, Phil Gurnett, who will be explaining to us what's going on and been going on at King's College Hospital, where he's senior resuscitation practitioner. So with no more ado, Phil, over to you.
Hi, thank you very much, Andy. I'm just going to set my slides up and then I'll start chatting. Shared. Excellent. It's got a red border around it, so you should be able to see my slides. Thank you very much for inviting me and asking me to come and talk about what's happening in King's at the moment. As Andy said, I'm one of the senior resuscitation practitioners at King's College Hospital. My background is as a nurse. I've worked in a variety of places, but particular emergency care and cardiology. And for the past sort of 12 years or so, I've been working in and out of simulation and with a little bit of cardiology on the side. And last year I moved to King's as one of the senior resuscitation practitioners, along with quite a nice, small but dynamic team that we have here. So I'm just going to go through what I've seen, so kind of what I've seen from the outside, and coming into an organisation where there's lots of simulation going on, but not necessarily joined up, coordinated in a way that a lot of organisations are at the moment. So it's more of my observations and a couple of case studies of what we've been doing. So as an overview of King's, founded in the 1840s, originally to train new doctors, and relocated to its home now in Denmark Hill in 1913. If you have a look at those little gateposts there, that's now part of the entrance to the A&E department at, or the ED department at King's. In 1966, it was developed one of the first liver units in the UK, and it still has a massive liver unit there. It's one of the biggest transplant services in Europe at the moment. In addition to that, it's a major trauma centre. We have one of the few hospitals in the country that has 24-hour helicopter access. We have cardiothoracics, neurosurgical specialities, renal specialities, as well as one of the largest critical care centres in Europe. Some of you might have seen in the news over the past few weeks the opening of our rooftop garden for critical care, which is quite a nice place to go up and have a little wander around if you ever get the opportunity to. We have two main hospitals. We have the Denmark Hill site and we have the Princess Royal in Orpington, as well as other satellite units around there. So it's quite a large trust. It's got over coming up to 15,000 employees, of which we provide resus training to the vast majority of them. It also has a dental school, an institute attached to it as well, but I'll talk about that a little bit later on. Our team is Resuscitation Services. Alex will thank me for putting the logo up there. We provide cross-site services around resuscitation training from basic life support to advanced life support. We review and audit all emergency calls, so all 222 calls that are put out, and all cardiac arrests, taking part in the National Cardiac Arrest Audit as well. We provide clinical support and review and risk assess areas as well. We're a small team, but we work across sites and we have quite a varied level of experience around resuscitation and simulation as well. And we will support the development of simulation across the sites. We also have at King's, we have the King's Academy. So this offers a full range of simulation within its dedicated centre at the King's Academy, which is just down the road from Denmark Hill. There are 2 multifunctional simulation rooms that have got amazingly well-connected debrief areas and control rooms as well. They're multifunctional in so much as we can move a lot of equipment out, bring in, set up as new environments, and they work really, really well. There is a dedicated simulation practitioner that supports the delivery of that, and we offer training in simulation design, delivery, and debriefing. We also support, the Academy also supports the in situ simulation that happens across the trust as well. But this is about transformative sim. So some of the observations that I've had around simulation since I started in September is that it's happening all over the trust. We have lots of areas of really good practice in simulation, and transformative sim was happening, just not in the vocabulary of the organisation. Simulation is contributing to the development of practice across the trust. We are seeing simulation being delivered, addressing some of the challenges that we have within the trust, and contributing to changes in the way people practice. However, because the TfS isn't in the vocabulary, that's not always getting the recognition that it should do within the organisation. And that also means that some of that shared learning is still in development. Despite the push for shared learning through PSURF and all of those elements, it is happening, just not necessarily happening in a formal, structured way. We are also not seeing things like SEEPs coming into the sim and the other human factors models that will help. And that's kind of the basis that we're building on from here. Sorry, 2 seconds, my son's just leaving the building. So some of the stuff that we're seeing happening at the moment, we are seeing monthly cardiothoracic sims. Originally, they consider this and I had a long conversation with one of their facilitators. They consider these as a learning opportunity, an opportunity to develop, to teach people about cardiothoracic advanced life support. So for those of you who have never worked in a cardiothoracic area or aren't aware, when we have patients that have had cardiothoracic surgery and they potentially have a cardiac arrest within 10 days after their sternotomy, we run a slightly different cardiac arrest approach to them. So we still do the normal things, confirming cardiac arrest, starting good quality chest compressions and all the other bits and pieces to go with that. However, our cardiothoracic colleagues turn up, and if it's necessary, they will look to open the chest in that area. So reopen that patient's chest and provide internal massage, internal defibrillation, and potentially address some of the reversible causes, such as a pericardial effusion or something like that, that might be causing cardiac arrest at that time. And I think that's how it's originally started. But the ones that I've attended, they're already thinking about, okay, how do we address our practice? How do we change what we do normally within our clinical practice from what we've learnt in these simulations? And it's really simple, subtle things that they're doing. For example, lighting's been raised in a couple of issues, bringing in a good enough light to be able to open the chest. And they, as a result of using it in or addressing it in the simulation, they're looking at how they can integrate head torches into their emergency kit, and will then try to practice that at the next lot of simulations before making it go live in their practice. So they are moving, then also looking to move those simulations out of recovery area where they currently run and replicate some of this stuff in their other cardiothoracic areas. So we have, as well as the critical care areas, we have a dedicated cardiac recovery unit and a cardiac HDU where the majority of our post-op patients end up. So that's where they're looking to deliver that stuff. But we've had a couple of real big wins within our practices. One of these has been a maternal cardiac arrest, and this is based on a real case. So in September 2025, a patient suffered a maternal cardiac arrest. This led to the patient being placed on ECMO. Just for your peace of mind, both mother and baby survived. However, the debriefs that we undertook showed that there was a need to review how we undertook maternal cardiac arrest. Now, there's two caveats to this. One, we are a referral centre for complex obstetrics and complex births, which means we see a higher than average population. So a population that could potentially go into cardiac arrest higher than the normal everyday maternity units. We also have ECMO available Monday to Friday and potentially outside those areas if needs be. So we're quite lucky in having that available within King's. However, maternal cardiac arrests are already probably one of the most complicated cardiac arrest scenarios to run, or cardiac arrest events to run. Adding in another big complex team as well adds to this massive complexity. So Dr. Pervez Khan, one of our critical care consultants, together with the obstetric team, ourselves, and our midwifery colleagues as well, came together and ran some sequential simulation, 3 stages of sequential simulation, pausing at the end of each element of it and then debriefing separately outside the room and identifying where we can change our practices. Some of the things that we were able to do within that was just to spend a bit of time talking about the case that triggered this and the challenges that people had, as well as how we can adapt the current guidelines within that. So the process of what we've undertook and what we delivered actually helped us to understand a maternal cardiac arrest as in the normal maternal cardiac arrest, but also how we can integrate ECMO into our standard operating procedures. And that work is now being undertaken to get that developed into that. The benefit of what we've experienced and what we've been through is that we're actually able to then look at how we can get that published and get that work into guidelines, which is really important, I think, for everyone that was involved there, that actually ECMO is becoming more common certainly in big tertiary centres as a potential option. We need to get that the team mobilised to us early, so that we actually get them on site and prepared early. And we also then need to change how we run our emergencies, because the way they want to run it means that they might spend a little bit more time without pauses doing what they need to, or indeed pausing CPR while they're undertaking their work. The beauty, I think, of this sim from my perspective is it brought together so many different clinical teams that had a shared interest in improving those outcomes. And from a personal level, this was the first time, I think, in about probably 10 years that I've actually took part in a simulation as a practitioner rather than as a facilitator, which is very cathartic and very useful from my end as well. As you can see, this was undertaken in one of our simulation suites in the Western Education Centre, and it looks very cramped. The reality of our obstetric theatres is they are also very cramped, and we probably had twice the number of people in the actual emergency as we have here in this simulation as well. The knock-on effect for that is from this scenario is that we were able to then look at some of the challenges we had around equipment. So we looked at using our Lucas device, which you can see a version of Lucas here. And for the particular patient we had, partly because of her own size and also the obstetric side of things, we couldn't get the Lucas into position for that patient in the real event. So we've been able to undertake just some simple work by getting all of the companies that provide mechanical CPR devices in, placing them onto a mannequin in our cath lab and seeing which is where we would most likely use these devices, and seeing what how effective they are and how useful they are around the imaging. So for example, you've got 3 examples on the board here. You've got the Lucas 3, which we use already. and that's used within our cath lab quite well for prolonged cardiac arrest, and it's also used in our ED department as well for a prolonged cardiac arrest. You've got the new core pulse up in the top corner, and that has just been rolled out across London Ambulance Service, and I believe there's a couple of other London hospitals that are using it as well. What this does is it removes some of the restriction of movement of the C-arm in the cath lab, because we're only using a single pillar to support the compression device rather than double pillar. And then at the bottom, you've got the autopulse, which had been used in the past, has kind of gone a little bit out of fashion, but has a new pre-hospital version, as you can see here, which we thought it fair to actually bring that in and trial that as well. And it's been quite useful just doing a really simple example of all three of these devices in a real location and seeing how they affect practice. This is a work in progress, and obviously, like everything, it comes down to money as to where we go with this. But it's been useful as a just to roll out and have a look at what is potentially available and how it would actually look in practice, rather than doing the traditional, right, you've got X amount of money, this is what's an option, this is what it looks like on a mannequin in a classroom or in a showroom. In case, pick one from that selection. We've been able to put them into the real environments and see what they actually look like in practice. But this is where our unexpected win has come in. So King has been delivering dental care for over a century. In 1966, it developed this new building, which you can see in the top corner. And this had remained largely unchanged since they opened it. In fact, the main change that you can see now compared to previously is you won't see any sort of car park there. We've built on that. And the entrance, as a result, is actually at the far end of the picture rather than in the centre. One of the challenges that we've got with old estate is that lifts are as old as the building, and obviously as we change, as our equipment changes, we can't just sit there and go, right, we're going to change all our trolleys that we've had for the past 10 years, 15 years, or we need to change the lifts as well. Changing the lifts is not an option. So they identified, as they've developed practice, that there was a need to review how they move patients that have potentially cardiac arrest or are unwell from one of the 4 levels that dentistry is delivered on, using the lifts and using the equipment they have normally available at that time. So back in 2024, the resuscitation services undertook a risk assessment on the access to the lifts. The way they've done that, as you can see in the picture at the bottom, is they've run a simulation. This is where I mean that transformative sim is not quite in the literature, in the language of the organisation at the time. So this is 2024. We had a simulation on one of the floors that shows that a patient had gone into cardiac arrest, and they needed to evacuate the patient during cardiac arrest. So we have quite a large cath lab, and we do actually transfer patients in cardiac arrest through the hospital to the cath lab if we need to. So it's not beyond the realms of possibility of this happening. However, it is an unusual event in most places and extremely unusual in the dental institute. But we thought they'd start with the worst potential outcome. The scenario was set up with an initial setting. So the patient complained of chest pain. 3 dental staff members were inside the cubicle. So if you have a look at old pictures of the Dental Institute, you will see that you see lines of dental chairs with dental students and dentists working together to undertake all the dentistry things that they do. And the only real change from the 1800s to now is they put little half walls up so that you don't actually see what's happening next door. But there's still big open areas that have got half walls up. So these little cubicles actually restrict space quite a lot. So the expected outcomes you can see on the side, which was a 2222 call going out, BLS being initiated by the dental staff, and the patient was going to deteriorate into a PEA cardiac arrest. We had 3 potential extraction outcomes for a patient that was in cardiac arrest. So you have the low difficulty one, which is the big lift being in working order. So there's 2 lifts in the building. One's a big lift that you can get a trolley into potentially. The other is a small passenger lift, which is quite limited. So that will be the challenging but manageable option. And then you have the high difficulty, which is actually transferring a patient with CPR going with the Lucas in situ. And you can see a picture of this happening with my colleagues and going down the staircase. The outcomes of that were that the lift was okay. The big lift was an option. However, the new modern trolleys that we had were actually a little bit large. So we actually needed to sit the patient up a little bit for that. The small lift, it was really limited for the staff to get into, as well as the patient as well. And the patient would need to be on some sort of extraction device to get that patient out. And then the staircase with CPR and going in Lucas, which was tried but deemed actually difficult and unworkable as an option. However, they did recognise that the movement of the patient in cardiac arrest is extremely rare outside of the main hospital site. There was a review of the equipment available, in particular for our patients. Although we've concentrated on cardiac arrest, the majority of the patients that we would go to wouldn't be in cardiac arrest. They would be deteriorating patients or unwell patients. And actually we could sit them in a chair, wheel them and use the passenger lift to get them out. But if the lifts were unavailable, it was quite limited on the extraction equipment they've got, and the training that staff got was hit and miss. So we brought in our moving and handling colleagues to ensure that actually that training was delivered as well. There was the development of shared mutual aid between floors. So if one floor has an emergency, the other floors tend to know about it. And we've seen that in some of our work that happened since then, where we said we're going to evacuate the patient, and then suddenly people are holding and preventing people accessing the lifts that we can get down. And there was suggestion of review of where bariatric dental surgery may take place in the future. So fast forward to March 2026. And the problem we've got was the lifts needs to be renovated. So excuse me, I'll just take a drink. So in particular, the big bed lift was going to be renovated. The win for us was that they were asked us to come back and see what we could do and how we could help them with this. One of the outcomes from the previous test 2 years earlier was that actually they needed an area for potentially difficult surgery that could be undertaken on the ground floor. However, the teams that were involved didn't think this was particularly fit for purpose. It was used largely as a junk room, even though it had been identified and renovated for that. So we went along with a plan to run a follow-up sim in the area where the surgery was going to happen, and help identify any potential improvements that they could make within that area. So the solution was an in-situ staccato sim. So if anyone's used to reading music, they'll know that staccato is a stuttering way of doing the simulation. So whereas the maternal sequential simulation, they ran a simulation, they stopped, went out of the room, debriefed, and came back in the room. In this case, we're running in situ, and we ran elements of a resuscitation. We kept this really simple. We brought over, as you can see, a basic CPR mannequin. We had a rhythm generator attached to the areas working defibrillator, and we ensured that there was someone around from a safety perspective to make sure that if something would happen in that area, we could disconnect our equipment quickly and support them at that point. We engaged with the teams who would need to share this room. And I think this is really important in so much as the teams were, although they work in different floors and although they know of each other, actually it was really useful having two different teams coming in and going, well, actually, we do our operation this way, or we do our procedures this way. And that discussion helped us identify some of the prior concerns that people had with the environment. And the sims were run over an afternoon with 3 facilitators from the resus services. As I said, we use simple equipment and live locations and equipment. So the area was up and running, or was open. However, this room in particular was not being used on that day. We had 3 visible issues within the area. The first was the piped oxygen suction. Put a little red circle there, you can see that. So this area had actually been renovated to allow people to access and run procedures and small operations in it. It was on the ground floor, and it's large enough for us to get extra large equipment in if we need to. So we can get a bed in, we can get trolleys, we can get a wide wheelchair in. It was designed for the bariatric patient. There are 2 of these piped systems set up, and previously they had some systems set up on the opposite wall. But people didn't like that because of the positioning that they had there, and because of other equipment that was in the room at the time. So we just simply said to them, well, has anyone tried these devices out to see if they're attached? And no one had. So we brought an oxygen regulator over, we chucked it in the oxygen port, and we turned it on to see whether it worked, and it did. So suddenly this area that they thought wasn't working very well had a potential to open up. So we strongly advise, and they did, get their medical engineering involved to ensure that it was safe and working effectively and being properly tested. But they actually went, if that works, this would actually transform some of what we do. The next issue they had was the lighting. So they have these fantastic portable lights that are very bright, and in fact, we have actually had a quick chat. I had a quick chat with the cardiothoracic team who said, who were looking for a light that they could use for their procedures. Dental have got one, and it works really well. So potentially they could use something similar to that. But the issue they had was where they could plug the light in. What you can't see in this image as such is in the bottom left-hand corner, there's actually an observation machine, and there are some plug sockets further along that they could potentially use. However, it would move, the patient would be in this orientation. The light wouldn't be over the patient's mouth where it needs to be. So orientation and the trolley itself became a bit of an issue. So the equipment location and who would get it. So those areas, that orientation was potentially something that we could deal with. But we also had 2 invisible issues that were sitting there. So our equipment location. Outside of this door, you'd need to turn right, and there's a large waiting area, and the equipment was sitting at the far end of that area because the majority of work happened through a door on that side of the building. Most people that work down here work in pairs. So you have a dentist or a surgeon and a dental nurse to support in that area. So one of them would need to go and get the emergency equipment while the other ones commence their basic life support. And actually, we couldn't address that as such, apart from ensuring they had an emergency bell available and a way of shouting for help. The calling for help, though, calling 2222 became another issue because there is no phone in this room as well. However, there is a door that goes to a reception area. So we talked to them about whether or not they could include their receptionists, who were going to be working in the area anyway, as part of their emergency team, and use them to put out the 2222 call if needs be. So those 5 areas were issues were what we identified. This is what the outcome looks like. So they've completely cleared up their area and changed and transformed their area. Apologies for the lighting of this, but as you can see in here, they actually chose not to move the light. They've kept the light in the area that it was and plugged in, but they've moved equipment around to ensure it can be plugged in. The bed is as it was, but it's orientated the other way round. And they have actually got further equipment, X-ray machine and drills available if they need to as well. The area at the back where the blinds are, that was all cluttered and covered, and they've actually gone, we don't need any of this stuff. So they've actually had a bit of a clear out from that. Please excuse the patient's chair that was hidden in there. As I'm sure anyone that works in any NHS hospital will know, getting a portering chair is like getting gold dust. So once you find one, you find a place to hide it. And I think this was the hiding place for this dental procedures. This shows quite clearly the back door that goes into the reception area. It also shows a portable screen. One of the concerns was people could access the door. Now it is restricted access in so much it's got a tap card that allows you to get access to it. But our suggestion was to use a screen across the door face to prevent people from looking in, and that's what they've done. They've just brought in this screen and they put that across the door if they need to, but as you can see, they've got a lot more space around their patient now than they thought they would have. They've played around with the Danny Centre with the gloves and apron that's sitting out there, and the clear wipes is all there, and they've got their piped oxygen and pipe suction set up on the opposite wall where they needed it to be in the first place. They've also gone ahead and actually arranged and checked and found that their phone system can be set up in that room. So they have put in a phone and they have got a computer system. So they've got IT set up now. It also means it links to, as you can see there, a little portable X-ray machine. They can actually then look at the images as well while they're operating or while they're undertaking procedures in that room as well. So all in all, this has been a really simple input that has had quite a big effect, to the point where the lifts have been renovated and they're still using the room for their surgery now. So just kind of to summarise, I appreciate it's been a bit of a whistle-stop tour, but TfS is happening at King's, even if the terminology is not known. We're in a process of developing a community of practice for SIM. So myself and some other sim geeks have got together and gone, do you know what? We need to be sharing this work. It's in the literature of what we should be doing, and we've got the people together. While it would be great to have lots of support from lots of big managers, let's just get some people together and start talking about what we're doing in sim. This is sim in general, but TfS will come out of that as well. And I feel that King's embracing the future vision that Gabba described in 2004. But with a realization that the landscape is complicated. So by that, and I love Gabba's article from 2004. Everyone quotes has the famous quote from the abstract that sim is a technique, not a technology. But actually, you know, he was predicting that by 2025, simulation will be embedded across healthcare, that we would be using it for more than just educational abilities, and that we would be looking at how we can integrate it across the board. And I think that's what we're doing at King's. I think that's what we're doing probably across the country. And we probably don't shout about how visionary that article and that observation of his was. And that's it from me, I'm afraid. Has anyone got any questions?
Definitely no need to be afraid, Phil. Thank you very much. It was a bit of a whistle-top tour, but very well timed, I think. And I agree with you. It's a very nice paper, that one, with all the sliders of all the different modalities and everything else. One that we can lose sight of. I'm waiting for hands to go up from people who have questions. Ken has a question. I have a quick observation, which yet again, this is a really good demonstration of SIM as the great connector, isn't it? And bringing people in from across the board. So I'm going to go to Ken Spearpoint first, and then to Torben second for their questions and comments.
Hello, Phil. Thanks for that. Very interesting. Good to see it all in action. My question is predictable, I guess, is that I'd be interested to know which debriefing models or hybrid versions of models were used in some of those TfS events, and how that debriefing was used to provide evidence and data to drive the change.
So the debriefing that I used in our approach was a hybrid of pearls, essentially. But if you really want to be technical, it's probably a hybrid of about 15 different approaches using a framework, sort of 4-stage type framework. However, I think it became much more of a conversation approach towards the end. Once people got comfortable in the dental sim that we did, the second stage was the one that I was involved with. Actually, it became more of them having a discussion than that I was facilitating, rather than me actually leading and going through a stage, because they suddenly had a realization that it was in their power to change things. In my opinion,
did you gather data? Did you take notes, or did you just store it in your head?
Yeah, no, we took notes. One of the facilitators sat there with a pen and paper, was taking notes, and we fed all that back to the area.
Pen and paper, did you say?
Pen and paper, Ken. Yes.
That's very old technology, Phil.
They were sitting down writing notes with pen and paper.
They've not got smartphones with recording gadgets on it.
I'm not going to say anything because Alex is on the call.
I didn't authorise the use of pen and paper, Ken. Just saying.
Yeah. But it worked. The notes were taken down, and they took on board. As I say, it's begun with me facilitating, and it ended with us just sitting back and letting them have the discussions, which we then summarise in a report back to them. The debrief for the maternity sims were recorded, and they have used that information towards the SOP. But that was recorded. But again, the models wise, this is where, and we've had this conversation before, I think the experienced debriefer will flip through different models, and it's more the techniques that's the important thing than the model. Making sure they're using open questioning, they're using inquiry and that's that sort of thing, and that tends to be, and that's what my experience has been with that approach.
Brilliant, thank you.
Lovely. So the scenario, almost the anecdote that provokes the conversation. So I'm going to come to Torben, and very much welcome to you. It's great to have you here, and then we'll come to you afterwards, Daniel.
Thank you. I'm Torben from Gothenburg, Sweden. Very interesting to hear. I was wondering if so these are very local problems. So I wonder if you had some more general insights or take-home messages to us that will have other local problems. If you have some insights, so that will be valuable for us to know in this process of transformative simulation.
I think the approach that I've had is to be quiet about it in a way. When people have asked, I'm always happy to explain transformative sim and push it and go through that stuff. But I think it's about slowly pointing out to people that what they are doing, yes, they're looking at it from an educational perspective, but there is also the opportunity to develop their practice and develop what they're doing and learn from the areas that are happening, in particular with the in situ sim, because it's really difficult for people to sit there and go, well, that wouldn't happen in real life, when you run a scenario and someone's really gone to a trolley, really taken out a piece of equipment and gone, I don't know what I'm doing with it. Because if they don't know what they're doing with it in a simulation, they're not going to know what to do with it in real life. So it helps identify the potential issues. I had one, not here, but another organisation that we had exactly that conversation, where they went to attach, one of the portering services had left a dust cap over the end of the oxygen bottle, which they would normally take off before they deliver it to the ward. And when they couldn't attach the oxygen to the bottle, they were like, what do we do? Something really simple completely stops the scenario, and we had recognised that was a latent threat. Now, the response I got back was that doesn't happen. So when I then showed them the picture to show that it has happened, actually people then started to accept that maybe there was something around how we test our processes. So it's about, for me, I think that the take-home message I would say is to go and try it, do it, but do it in a way that allows people to be comfortable with what they already know, but also introduces the eyes that you have from the 7 eyes from the taxonomy.
Thanks, Phil.
Thanks a lot.
Thanks. I have to add a comment to that about this sense globally, if you like, Torben. It's about how you make yourselves the go-to guys to find solutions to problems or discover better solutions. And I think the word that I would accent, which is mentioned in Gapper's future paper, is about just to say that simulation is safe. We will make this safe for you to experiment and discover. I think that would be what I would accent. But thank you. Nice question. And Daniel.
Hi, Phil. Thank you. Great talk. I think in establishing sort of where we go and how we disseminate and build a community around TfS, I think, you know, with the brilliant work that was done with the team, you know, we're starting to dial this in, you know, these SBIs and establishing intention and using intention to rationalize our approaches. I'm just wondering, like, some of the phrases that you use there, like staccato, I use stop start.
Yeah.
And a walk through, talk through, and we're starting to build up an understanding of these approaches and perhaps even starting to find our way and align those with the SBIs as well. I think it's a question for yourself, but also the wider kind of SIG and the expertise that we've got in the room. But is anyone aware of any kind of toolkits or work being done around, you know, the taxonomy, the categorization, the classification of these different approaches and those activities?
I'm going to defer to Sharon.
Hi, Daniel. I'm just thinking this is great because you volunteered to help us do that. So it's definitely been thought about, and there's definitely work that we need to do there. And as we said, this is a community approach that we all need to be building on it. And I think now that, like you said, we're clearer on the intentions and all the different ways of using it, we probably need to do that. But yeah, maybe that's something we need to kind of think, we just need to think about how to do it. You know, is it best on a website that we start aligning it, having like different sections or something so people can go to, or do we need to write some papers about it to make it a bit clearer how they align? I think it's a body of work that everyone kind of has to contribute to in different ways. But I guess that's what we need to do as a community, is work together and figure out how we do that quite intentionally as well, and with some clarity. So if you've got suggestions and things, yeah, please get in touch and we'll take it forward, but definitely a next step.
Thank you. Thank you very much.
Very interesting. I'm looking around the room. I don't see any more hands up at the moment. Marco. Marco,
very curious to hear what you're going to do next, Phil.
So Friday is endoscopy. So I think our next step, big next step, is community practice. You know, everyone knows that I'm a sim geek. That's fine. That's fine. But I'm working within a particular role, and we've got to be aware of, you know, where our roles overlap and where actually we need dedicated teams for. So, for example, this Friday in our organisation, the majority, we've got a lot of audit sessions going on. It's not possible for our small simulation team to go and provide everyone the sim they want. So everyone's going to do their own thing. But if we can get a community of practice together and start to work together to standardise some of the approaches, but also recognise where people are doing twice the amount of work they actually need to simplify stuff, and learn from each other. And that to me, I think, is the important part, because there is so much work going on in isolation that is really important to the whole of an organisation. And if we're not sharing that, then we're missing it's a big own goal for ourselves, you know, to use a football term. Hopefully no own goals on Wednesday, but yeah, it's a big own goal for an organisation to have lots of really good work going on, and not being shared amongst themselves. And I think it's, if anything, coming from a little organisation out as an NHS organisation into a large organisation. I think it's very simple. It was very simple for me when I was at Darren Valley to, pick up the phone to the Deputy Director of Nursing and go, look, this is happening here. How do we stop it happening here, here and here? It's not simple to do in a large organisation, but I think that needs a bit of change of understanding at the top, as well as an understanding further down how we can get those messages up. And I'm not just saying this because he's sitting on the call, but I do have good structure and ability to do stuff in the team that I'm working in. I'm aware that not everyone will. So it doesn't really answer your question. I've given you a political answer there.
No. But it is interesting then how are you going to get to that point where you get the rest of the organization to just realize that they should be using this all the time?
I think I'm going to upset a few people. But I've done that before. It's not the end of the world.
It's amazing how much of this comes back to human factors principles, essentially, and we are all aware of the difficulties embedding human factors in healthcare successfully. So,
yeah.
And saying that, I think the in situ stuff is a really good demonstration of good human factors practice, because it almost turns the practitioners into perfect probes of the environment and the system, rather than looking for faults in the practitioners. But still, Colette, over to you.
Thank you. My background is from the ISO standards on all sorts of things that I'm going through at the moment, and actually it links to what I wanted to comment. So well done, Phil, love it. We have to shift to moving upstream and looking at the everyday, I think, but I have also realised, having just done a human factors ergonomic simulation for maternity myself, that I know we're both working in two very large organisations, but you are now the third organisation that I've heard within the last less than 3 months who have done a large maternity related simulation. So there also needs to be some kind of shared learning, because I possibly don't need to go and repeat that. I don't know, I forgot the Lucas thing. I know that wasn't the maternity. Well, yeah, it was the maternity one. But I don't know how we do it. And half the problem that I have posed before is that, I'm sitting on a whole load of data from last Friday's incredibly good sim, but I don't have the time to analyse it appropriately and get it into a form. And I think that's the bit we've got to start working on. And the other thing was, I think that I know we do collaborate, but Andy's just hit the nail on the head, I think, and with Dan's comment, the language and the work, I think transformative simulation and human factors ergonomics has to really start trying to come together to help make these tools accessible, because we've got to teach people how to use them, because we know how to use them and we know how to debrief, and we're learning how to use some of the human factors tool, but we've got to try and get it out there to the everyday. And I think some of that is through simplification. So it's a lot of words there. Sorry, Andy.
No. I think it's a really valuable comment, and it all springs back to what our three questioners have been asking as well. And we used to say this is why you publish, but the publication world has got so vast that nobody has time to keep an eye on the horizon of it all anyway. So I have the president of ASPE and the immediate past president of ASPE in front of me. I'm wondering whether we should rethink, Sharon, we did try this, but whether we should rethink the repository for dirty data and sharing on what is happening in transformative sim. I think we can hold our heads up high about the taxonomy, and we didn't invent it, we described it. It's going on, people are doing it and they're trying to do it, and people want to be, like Julie Martin has successfully done, stand up and be the go-to person for this sort of problem solving. Where do we gather it all? Because the journals aren't quite working for us at the moment. Maybe that's something that ASPE could offer. And Phil and Sharon had a hand up. Phil, do you want to comment?
Did Sharon want to say a comment first, and then I'll come back? It's probably slightly different.
Yeah, it's just to respond to that, and I think you're right. We had the template, didn't we, initially years ago, but no one was really completing it apart from Julie. But we could definitely bring that back in, and I think maybe find a more intuitive way to use it on the new website, maybe, because I think we're at a stage now, you're right, Colette, where people could input to that quite easily. I think in the past people were still getting their head around the difference between transformative and education, because that was about 5-6 years ago we did that, wasn't it? But I think it's probably the timing's better now. So yeah, good point.
I think that kind of brings on to my point as well. I think we also need to be aware of we've got lots, certainly in large organisations, you've got lots of people that have done some sort of simulation and they see the simplicity of it without understanding the complexity. So they go and do it, and then they hear about transformative sim, or they've heard about some systems change sim. So they go, well, that's just writing another scenario and running it. And I think that's kind of, we need to be aware of that as well, and how we can support those people in developing, rather than just going, oh yeah, great, fantastic, off you go.
Yes, the eternal risk of simulation done badly.
Yeah.
Yeah, and I just want to respond as well to that, but also Colette's point about the data earlier, and I think one of the issues with the data when we kind of just run a sim, but we don't really have that kind of intentional design lens like we've been doing, Colette, with the bow tie and stuff, is that you can be quite selective on how that data is interpreted. And even if you use some of the tools out there and stuff at the moment, if people using their phones and everything, how that data is then interpreted and used in practice is quite subjective and can be quite reinforced biases and problems and how we're seeing it, as we know. So there is something about, I think if you do use the theories like we've been doing as the lens, you can be a bit clearer on how that data is coming, isn't it? And then it's easier to collect. And I think we probably need to make more emphasis about that going forward and make that clearer. And I guess some of the work you're doing, Colette, will actually help with that as well, though, in a lot of ways.
Yeah, I just this is a comment, maybe I shouldn't be saying it, but I know when I was so desperately trying to make simulation mostly for education, but we were also doing transformative sim without knowing what we were doing, making it safe, we were accused of controlling and stifling the creativity. So I was going to try and write that in the chat, but I can't get the words right. But there's a risk, isn't there? You want people to do it, but we know that done badly, it can really be damaging. And what I worry, and I think that's what you're helping me articulate more, Sharon, and I touched on it the other day at a little sim event that was being run, that Andy was there, that I touched on that point we've been discussing about the ethics of the information and what we do with it, and making sure we do something with it that's right. So there's all of that. It's like spaghetti in my head at the moment, because it's not knowing which bit to tackle first, but tackling it and helping and enabling is the right thing. And I know that's what this group has been doing, which is what's so wonderful.
So you have spaghetti in your noodle.
Yeah. And I'm sorry for the casualness, but it is my day off because it's my birthday, so I may well be having spaghetti for supper later. So.
Happy birthday!
Happy birthday!
Thank you. I didn't mean it for that, but I just feel really bad. I'm really casual. I thought I did want to join and hear Phil though.
I hope you've got some cake.
Wonderful. Happy birthday, Colette. And we have 5 minutes left. So I'm going to, and I don't want this to turn into too much of a, I don't know, a cliquey ending, for want of a better way of putting it. But I'd like to hear, Phil, you've presented, you've been hearing all the comments. I'd like to hear from you, and then I'll go on to draw the meeting to a close. Thank you to our 30 attendees. Phil.
Yeah, I mean, it struck a bit of what Colette said, struck a bit of a chord with me about when you go back to ergonomics and that side of things. You do a hierarchical task analysis and you will have so much information, and the skill is identifying what are the must be addressed, what are nice to be addressed, and what is completely irrelevant and has no reason to be addressed. And it'll always be the people in the process will always want to change something that's completely irrelevant, and you're never going to please everyone. And I guess that's the same with what we're experiencing now when it comes to our transformative sims. We've got to develop those skills in that identification of the key areas that have got to be addressed. And that's probably where so in my practice, and I'm sure other people need to develop. But that's it from me. Thank you.
Wonderful. Okay.
Can I come in with one last bit, Andy?
Yes.
Yeah, and just because I want to add to that, Phil, but it's reinforcing as well. I think because of this kind of fallacy, and I keep saying it a lot, I know, but you know, we're replicating reality, and we know we're not replicating reality. We're making choices about it. There is something really, but I think it's such a strength that we can choose the bits of reality we want to elevate when it is so complex, so we can have that focus on what we need to. And yet I don't think we're always seeing that sometimes, are we? We're seeing it as maybe a limitation, like you said, Colette, about control, but it's not. It's just illuminating the bits of the complexity so we can unpick them. And I think maybe we need to get that message a bit more across with transformative sim, because I think it's quite powerful.
I couldn't agree more. I think it's something that every analyst tries to do, isn't it? Is to pick out the bits that you can deal with. Right. So thank you, Phil Gurnett, for that presentation. Thank you, Alex, for letting him present it. Thank you for all your questions and comments. This is just a reminder that our conference is in the lovely Harrogate in November. I've booked my hotel, so if you want to know where I'm staying so you don't stay there, I'll let you know. And to let you know that in September we will be having another in practice seminar. Please do let us know by any means that are available to you if you would like to share your experiences. And I'm equally interested in the null result is still publishable, isn't it? Torben, you know, have you had experiences in trying to do this? Have you had experiences trying to collaborate with others in Sweden around this? We'd be really interested in hearing about that and thinking about it. So we're calling out for people with pragmatic experience of the practicalities of transformative simulation and those layers of collaboration. ASPE is in November, and in September we have a Professor Sharon Marie Weldon exploring patients, families and communities becoming active partners in simulation. So this is about some really interesting and both mind opening and engrossing work that has been done. So 2 o'clock. Thank you all very much for your attendance. Look forward to seeing you in September. And
Thank
do
you.
take care.
Happy birthday, Colette.
Happy
Thanks,
birthday,
Andy.
Colette.
Happy birthday, Colette.
Happy birthday, Colette.
Oh, you're all
Happy birthday, Colette.
diamonds.
Thanks for
Thank you
listening.
so much. Have a great day, everyone. I'll eat cake
Okay.
for you.
I'm coming round to get some.
Thanks, guys. Bye. Sorry for not using any fancy equipment, Marco.
Oh.
See ya. Let me
Somebody's been